Well, thanks for coming and sticking around. I got a call yesterday morning asking how long I was going to speak. And I have to be real honest, I sometimes don't look at the agenda really close. So I had no idea. But like this block is apparently an hour and a half. But Christy is in the other room and hers is only half an hour. So, and Christy and I drove Christy down here and we're staying in different hotels. So I told her, hey, come get me when you're done. So we'll work through this. But if you have questions, she'll have to wait, okay? And in preparation for this, Mr. Previous Speaker, I didn't go jogging in Zions yesterday, so I'm all prepared. I did go to Texas Roadhouse and eat a bunch, though. So, okay, so you can see the objectives up there. The top 10 are actually top 11 because there's a whole bunch that have tied. But first, we're going to meet the surveyors. Now, we've only done a very few surveys in what we should have done so far this year. And we'll talk about that a little later. But there have been changes in some of the survey staff, and frankly, many of you probably haven't met some of the new surveyors. So Lori Maroney and Dawson Croxell, they are our new surveyors. Lori came from she was a nurse at the prison. She's awesome though, you'll love her. And Dawson's a registered dietitian. I missed one up there. Shalise McKay, she came back to us. She was a surveyor with us for a little bit, left for a year or so, and decided we were so awesome, and she came back. So Sandy Johnson, you'll probably get to see her again on your side. She's finishing up with her clinical work as a nurse practitioner, and so she left the survey agency, but like I say, she'll probably be in your neck of the woods, at least in some of your facilities. I think she's been working with Dr. Baird. Does that name sound familiar? Okay. So all of this shows, the reality is that we are down 5 surveyor positions from what we were before COVID. Over the last several years, as the state has gotten raises, the federal budget has been static for about 8 or 9 years. So the state, when the raises come, the federal budget static, we no longer have budget for more surveyors. So we got to work that out between the state and the feds on how to get more surveyors. Because even if we got back up to the 17, 18 that we were before, I don't believe it's going to be enough surveyors for what our workload is now. When CMS required the investigation of facility reported incidents, triaging them, categorizing them, that workload has been significant. And we'll talk about that as we move along. But this is your survey team. Okay, so we have done 20 recertification surveys since October 1st. So if you're doing the math, there's 98 facilities. We've done about 1/5 of the facilities in a year. And the federal requirement is, we have no facility greater than 15.9 months and a statewide average of 12.9. So in order to have that statewide average, we need to be doing about 98 surveys a year. And 6 months into the year, we've done 20. So we're nowhere close. There's a lot of factors when you look at the surveys in there. We've got a mix. We have some facilities that have done very well, a couple deficiency-free, and then we have a few that have not performed as well. And with the survey staff that we have, including some new surveyors, some of the surveys that are in those higher numbers, those surveys have consumed a survey team of 4 or 5, upwards of a month when you consider the on-site survey time as well as the write-up time. And so that's a pretty significant factor in why we've only been able to complete 20 recertification surveys. All right, so for the top 11 deficiencies, and I apologize, I have to keep looking back to see what we got. So 6 through 11, they were all cited 6 times in the 20. F611, and what you won't see, and I want you to all feel really bad for me. You won't, but I want you to. While you were enjoying your Easter, I spent 10 hours going through every deficiency that we cited on those 20 surveys to see the top 10, and not only, because I usually just say, well, these are the kind of things that we cite on those top 10 deficiencies. So I went through and actually kind of jotted down some notes of what we actually cited. So these are from the actual deficiencies that were cited. And these are the scope and severity of the deficiencies at F761. This is not a deficiency that is ever cited at a real high scope and severity, so D's and E's. All right. Guess I'm going to have to use this. And this one's pretty easy. So medication refrigerator. Had medications that specifically had identified a range. Where's the sweet spot? All right, identified a range for the medication, supposed to be between 36 and 46, but the medication refrigerator, based on observation, as well as what was being documented by the facility, was between 30 and 35. Medication carts left unsecured, unlocked, in a resident or a secure unit, residents with dementia, all around. Medications left, so they'd been dispensed, but left on top of a medication cart. Again, the nurse left, the medications were unsecured, residents were in the area. Multi-dose vials, a lot of those were insulin, not a date that they were put in use. So most of them will have a date once they're put in use when they need to be used or discarded. Missing narcotics. There was a situation where there may have been some issues with a nurse and some narcotics, but the narcotic count was not on, and the facility wasn't doing. It was just continually the narcotic count was just off, and they just kept going about not doing anything about it. And expired medications that were still in use and still being administered. Okay, F758, again cited 6 times. This is free from unnecessary psychotropic medications and PRN use. And these are the scope and severity. Okay, so residents on psychoactive medications without consideration for a gradual dose reduction or a dose reduction. I will say that in some of the reviews that I did have some question about myself, whether or not, just based on what was written, if it really supported noncompliance. I don't know that it made real strong case for noncompliance. Just again, based on what was written. You know, that, I mean, the surveyor may have had some other information that they were going on, but as written, I don't know that it made a real strong case for, I think it was an anti-anxiety medication that was being used for spasms, muscle spasms, versus anxiety. So not always right. I don't know that one was, an IDR was requested, and I'll certainly will have discussions with survey staff about it. But I did have some questions myself about that. Other times, there were residents on multiple psychoactive medications, and there was no indication of a dose reduction or any apparent discussion of even considering that until after the surveyor had discussion with the staff. After that discussion, there were notes that the physician felt that a dose reduction was not, or was contraindicated, and made notes about that. But again, when there is a contraindication, which there can be, there are reasons why it can be, but the record needs to include that documentation. There needs to be supporting reason why it would be contraindicated to do that. Another one that I questioned it a little bit, a resident on hospice was receiving Haldol PRN for terminal agitation. I know that that's a common medication for residents on hospice, and it's sometimes just on their list of medications that may be administered. I don't know that we looked at that as thoroughly as we probably could have. So, again, we'll be doing a little more education on our side as well. Okay, F684, which is the general quality of care tag. Scope and severity, we did have one cited at a harm level. So one instance, a resident had a fall with a hit to the head. With orders for neural checks, and there were neural checks that occurred for a short period of time. They weren't continued. I believe on that one, the resident actually died a short time later, and I'm not exactly sure the overall condition of the resident prior to the fall versus what actually led to the death, but as a contributing factor, certainly the fall, and there were some, I just don't know what all, the neural checks just didn't occur though. And there were a couple of instances with residents that had orders for follow-up care with different physicians. One was with an orthopedic. It didn't occur. One had treatment for a skin infection, and there was not follow-up for the skin infection for a significant amount of time. One resident had complaints of a rash that extended a significant amount of time as well. I don't recall exactly how long, but ultimately the resident had scratched themselves to, they were bloody in multiple areas. They had scratched themselves till they bled. A wound that had developed, and it was 13 days before there was treatment. And instance of a resident that was admitted had 2 sets of orders that were, in some instances, inconsistent. And there was not clarification to get those in alignment. And again, another resident with a severe rash knot that didn't receive treatment. Testing. Okay, F677 care plan. Not my favorite tag, but it's development of care plans. One of them is again cited at a G. One of my least favorite tags, and one of my least favorite there, lack of toenail care addressed on a care plan. But in fairness, the resident had thick toenails that no one was addressing. A resident with significant weight loss, care plan didn't address it, that had requirements or was assessed as needing max assistance, wasn't receiving it. And based on observation, I believe the resident shows up in another area as underweight loss as well. Resident with incontinence, the issues with assistance for incontinence not addressed on the care plan. A resident not getting assistance with showering. And a resident, and I believe the circumstances were, the resident required extensive assistance with setup, and they had, I believe it was a stroke that affected their non-dominant hand. So they needed to eat with their, well, it affected their dominant hand. So they had to eat with their non-dominant hand, but they just were not successful with that. And so they required more assistance. But staff would come and set them up, but not provide any other assistance. And either the food would spill all over, or they just were not able to eat. F584, safe, clean, comfortable, home-like environment. Scope and severities. A lot of housekeeping type issues. I think this is one of the areas that's probably a victim to some staffing issues. People that may have assignments to clean wheelchairs, do some of those things, may just not have time to do it. And so how are those things, what are we putting in place to make sure those things get done? But I don't know that we need to spend a lot of time on that. By the way, today I did email Brittany the slide presentation, so she'll send it out to you. Okay, F78, request, refuse, discontinue treatment, formulate advanced directives. I was a little surprised that this was in our top 10. Scope and severity, had some inconsistencies where resident had a post that was, did not want treatment, do not resuscitate, do not intubate, and the facility electronic health record didn't have anything, and so the staff said, well, we'd do a full code. There were a couple instances of that. All right, this is another development of care plan. This is one is development of care plans for residents. I think 56 is for residents that are totally dependent, and 77, I think, is those who need one's for totally dependent, one's for that needs assistance. But wound caused by a Hoyer lift, and we'll talk about that in another tag. Care plan items that areas that are just left blank in the care plan. Residents' use of oxygen and respiratory just left blank, or not addressed, I'm sorry. Lack of follow-up for residents who smoke, care plans not consistently implemented, care plans not addressing UTI, pain, or falls. And again, not addressing respiratory function or oxygen use. Infection control, F880. By the way, CMS recently issued, I think I had it sent out, or send it to Brittany, guidance on the infection control surveys We no longer have to do the 20% focused infection control surveys. So we'll be doing the recertification surveys, and there will be a focused infection control survey as part of that, but we will not be doing the additional focused infection control surveys, which is the most significant part of that is the enhanced enforcement that comes with infection control deficiencies, which CMPs is a significant part of that. So hopefully that'll ease things a little bit. And these are not even really, most of these are not really COVID related even. It's just like, really? Taking off a dressing that's got a lot of drainage and not changing gloves before putting on a clean dressing. There is observation of not wearing the appropriate PPE. People coughing, not covering it, and based on the deficiencies, it was just kind of like coughing just out in front of, I don't know if it was like coughing in someone's face, but it was inappropriate the way that it was described. Not following transmission-based precautions, people coming in and out of rooms with contact precautions, going from room to room without performing hand hygiene. Nurse coming out of a room or carrying resident water mugs, setting them on the floor, and then picking them back up. Hoyer lift in a isolation room, then used in another room without disinfecting. Several instances of handling medications with bare hands. Handling food with bare hands or without performing hand hygiene. This is again, I have a smooth spot in my brain for stuff that happens in the kitchen, but a couple instances of food falling over, ready to eat meal or food, uncovered food, expired or past the use by date. You can read the rest of that. Okay. Unnecessary drugs. Again, unnecessary. It may be a very appropriate drug. I don't like the title of the regulation. It may be a very appropriate medication, but it's unnecessary if there's lack of indication for use, without adequate indication, in the presence of adverse reaction. There's a list of things. And what we have are multiple examples of residents that have medications with parameters. Do not give if blood pressure above this or below that, and the medication's given when it's outside of those parameters. Or it's held and there are no parameters, but there are no indication in either of those instances of the prescriber being contacted to discuss what do you want us to do in the situation. One of them, an individual on an antibiotic prophylactic UTI for more than, or nearly 2 years. It could probably fit here. It could probably, and maybe it was, I didn't look to see, look under the facilities antibiotic stewardship program, what you're doing, what's going on there. But this is where it was cited. All right, the number one cited deficiency in the last 20 surveys has been F689, which is the supervision to prevent accident or accident hazards. And several Gs, an immediate jeopardy at K. So a resident sustained a skin tear to the scrotum during a Hoyer lift, required surgical intervention. Resident fell from a shower chair as the CNA was pushing it, it tipped over. Sustained fractures. Interventions to prevent falls were not implemented. The resident fell, sustaining lacerations. The resident wheelchair tipped over in a transport van while being transported from dialysis. Minor injuries on that one. Failure to implement policies and procedures for residents who smoke, including assessment, interventions, monitoring, and evaluation. Resident sustained thermal injuries when he lit a cigarette while smoking. Resident toes run over by shower chair, pulling 2 toenails off. Multiple residents with recurring falls with no to few interventions, and staff unaware of the interventions. And a resident assessed as requiring supervised smoking was not supervised. So those are the top deficiencies cited. So again, we've completed 20 surveys. Not nearly enough, but there are a lot of factors that play into that. Eight of the surveys, so 40% of the surveys have resulted in harm level deficiencies. And I'm curious your thoughts. I mean, that's high. It's really high. Staffing has not been cited. It's been cited on a couple of the surveys, but it's not been cited on many. But as I look at them, and on a couple slides yet to come, I have to think that staffing plays a significant part on a lot of these things. So I guess, well, let's get through, because at the end I do have an area for questions and discussion. So we'll get through there. So facility reported incidents and complaints. This is where another significant portion of our workload is. So in October, we had 18 complaints, 1 at IJ, 7 at high. So with an IJ complaint, we have, based on new thresholds provided by CMS, between 3 to 7 days to investigate. Complaints, we have up to 18 days with a state or an annual interval, average interval of 15 days. So we had 7 high. We had more complaints than that, but that was just the the number of high. Based on the data that I had, I didn't count all of the other complaints for that month. And we had 160 facility reported incidents in October. In November, we had 13 complaints. Of them, 13 complaints, 3 of them were high, and 131 facility reported incidents. December, 18 complaints. By the way, December is historically a higher complaint month. More visitors, more eyes in the building, more guilt, probably a factor, reasons to call in complaints. January, 11 complaints, 1 IJ, 3 high, and 129 facility reported incidents. And then February was a banner month, 21 complaints at 4 high and 128 facility reported incidents. And so far, or in March, we had 18 complaints, 7 high. I believe that's 166 facility reported incidents. So facility reported incidents. Back last time we met, we talked about hopefully soon we'd have the ability to report them, submit those reports online. The time has come. So the forms are now available on our website. The website, when you get to the slide, or when you get a copy of the slide, those will be active links, but this is also a kind of a step-by-step guidance on how to get to those forms. So you'll be able to go in and complete those facility reported incidents. The thing, you saw the numbers of facility reported incidents. If you find yourself as a facility repeatedly, daily submitting facility reported incidents, and please don't take this as let's not report things that are reportable. That's not what I'm saying. But if you find yourself as a facility that is reporting daily or multiple times daily, I think it's time to really evaluate what are we doing? Why do we have so many events, reportable events occurring? What systems do we have in place to prevent these things from occurring? Because these events have outcomes. Something's happening to our residents, at least allegedly happening to our residents, and in many instances are happening. I was very surprised prior to October, and where these started, we had to start categorizing. I didn't take a real significant look at reported incidents. Leslie was here and she looked at them, and if something was big, should forward it on to me. But it's amazing to me the number of fractures that just all of a sudden appear. Don't know why it happened, out of the blue, or fractures that occur during care. And I understand we're dealing with a fragile population, and some residents have conditions that make them more susceptible to injury, which means staff have an expectation of being that much more careful and trained as they care for them. But it's been shocking and eye-opening for me to see the number of instances where residents have got these fractures. And the staggering number of resident-to-resident altercations. Wrap it up. But it's alarming, and it just really, well, let's get to the next slide. So, since March of last year, we've cited abuse 18 times. Now, historically, we've cited abuse, but 18 times since last March. 6 of them have been at the level of immediate jeopardy. 1 at an H, so substandard. So the IJs are obviously substandard quality of care as well, but H, substandard quality of care. Then 6 at a G, and 5 at a D or an E. So again, I talk about staffing and what leads to abuse. There were some of those, the reported incidents have to do with staff to resident abuse, and a few of the deficiencies have been staff to resident abuse. But the systemic ones, the IJ ones, have really been associated with resident to resident abuse and facilities that really have not had systemic plans in place to ensure residents that have behaviors, and frankly, residents that have behaviors, sexually acting out behaviors, that they are being adequately supervised. And as a result, other residents are being abused. And that's just so unacceptable to just tolerate. I know that there are challenging populations. But I guess I'm just curious about what your thoughts are, what your input is. In many of the higher level, the majority probably were not self-reported. That's not to say that all were not self-reported. I would say the ones that we're dealing with as being cited are probably not self-reported. Some of the staffed ones probably are self-reported. But I don't want to give the impression again that, and I think the question came up in one of our last meetings about the motivation of substantiating an allegation and reporting it. Are we just inviting a deficiency? And I think my response was somewhere along the lines, well, it's a requirement that you do that. But I guess the other part of that is there's still abuse that occurred. And we have to prevent abuse. And we can minimize, well, that resident was so cognitively impaired that they didn't realize that they were being groped, or they didn't realize this, or whatever, or even the resident, well, it was consensual. Well, if you have two residents that are severely cognitively impaired, that are going about the facility just randomly, just acting out in sexually inappropriate behavior, touching, whatever the behavior may be, and by chance, they meet up with each other. And so these two residents with sexually aggressive behavior now connect, and that doesn't make it a consensual act, because so I guess, yeah, some of them may have been reported, many of them were not reported. They just didn't have systems to even recognize. A lot of them just were discounted. Though I think, and unfortunately from administrative type staff, well, how can you prevent it? Those things just happen in this population. And that's a frightening way to consider things. Right. Yeah. That's actually not new from October. It's been around forever, but. I don't believe that's on this, because from our office, the question was, is the reasonable person standard factored into this? I don't know that it has, because in our office, that concept of using what would a reasonable person, for a person who's unable to communicate, express themselves, what would a reasonable person feel, believe, express under a similar situation. That standard has been around as long as I have. So, and we've taught that to surveyors as long. I think what we're seeing more, and I think it's manifest in abuse and accident hazards, is we have staff that simply aren't able to be more than one place at one time. And when we see interventions that are to increase monitoring, and you see the same interventions for preventing abuse as you do for preventing falls, well, we're going to increase monitoring. Well, who's going to do that? If you've got staff that are barely able to do their usual assignment, and then you ask them to do Q15-minute checks on however many residents that are at increased risk for falls, And however many residents may have behaviors that may place other residents at risk for being abused, well, who's going to do those Q15-minute checks? If you haven't added more staff to the equation, you've just added more work for the people that are there that already can't do what they're normally doing. And frankly, you know, civil money penalties are substantial these days. And what happens when you get hit with a hefty CMP? Where's that money going to come from? Is it going to come from staffing budget? And residents that have behavioral complexities that make them at risk for falling or make them at risk for interacting with other residents in what may be an abusive way. In many ways, those are probably more difficult to address than someone that is more medically fragile. Someone that's more medically fragile, they may follow a more predictable course. You know, we need to do this, this, and this, and this. But behaviors can be random, unpredictable. You never know what's going to set them off. And if someone's agitated, it could upset several people. And how do you anticipate when that's going to happen? And so when things escalate and your staff are already at a breaking point, what are they going to do? Who are they going to call? And it's not Ghostbusters. But who are they going to call? And when staff call in, then you have an unfilled shift. So I get that this morning's discussion was about marketing and filling beds. And there is a definite need because hospitals certainly are saying, we got to get rid of people. We can't keep them in our facility, in our hospital. They need to be in a long-term care facility. As a long-term care facility, you've got to know what your capacity is, and you got to know what your skill set of your staff is and what their competencies are. I wish I had answers. I don't have answers. I can point out some problems, but I don't know what the answers are. But your obligations are to the residents that occupy beds in your facilities right now. Potential residents are an issue for another day. You got to worry about the people that are occupying your beds today. And you've got to make sure that you've got the staff that can care for them today. And Saturday night at 3 o'clock in the morning, and Sunday, and every other time. So you just got to be able to, whatever your weakest staffing time is, you've got to be prepared to meet the staffing needs of your residents then. Because that's when stuff's going to happen. And if it happens and you know residents were susceptible to those behaviors and residents were abused, then you're part of the problem and then you should be cited. And you should pay civil money penalties because of it, because you could have fixed it and you didn't. And I hate to be kind of a jerk about that, but dang it, it shouldn't be happening, and I'm sorry, but now you can toilet paper my house and throw eggs at me and all that stuff, but what's that? Oh, yeah, eggs are expensive. So moving on. So yesterday ended, a period for a request for proposal for, we need help with surveys. So the feds gave us an amount of money that's only good through the end of this federal fiscal year, so the end of September, for help with surveys. So we had a RFP go out for, there's a few contract agencies, entities that do surveys. I don't believe, just based on national calls with other state agencies, I believe that the other, or these, so there's CertaServe, HMS, and Accelon. Those are the three I know of. I believe that most of them are about at their capacity too, with their ability to help states with surveys. So I don't know what kind of response we're going to get, or if we're going to. But we are in the market, so you may see that in the near future, we may get some of that assistance. So, but if we do, we'll be sure to communicate that with you folks and let you know. Okay? Any questions? Any good things that are happening in the world? No, not a dang thing. All right. Well, despite all of this, forget about regulators. We are only around every once in a while, but you're there every day. You have the opportunity to be the beacon to your staff. You can do all of the positive things that you've heard today from previous speakers, to motivate your staff, to do good, to just have a positive influence in the lives of your residents, because that's what they deserve. They deserve, in the end of their life, for most of them, to come to a place where they feel loved, they know they're going to receive the care that they need, and just enjoy the visits from their family, and to be comfortable. And you can help provide that. So go forth, do good, and thank you for the invite. Take care.